Good afternoon, everyone, or good morning, everyone. Welcome to Families Together's Town Hall on Mental Health. As many of you who have attended in the past know, this is an opportunity for families and young people to be able to ask questions of the chairs of the mental health committees in both the Senate and the Assembly, as well as the Commissioner of the Office of Mental Health. And we're thrilled that those three people have joined us today because they recognize the importance of the family voice and the youth voice, and the importance of being able to respond to us about what our questions and concerns are and let us know what they're doing in Albany to help. So I'm Paige Pierce, I'm the CEO of Families Together, and we're thrilled to be able to have these town halls. We've had, this is our third one this year in 2024, and we have 3 more to come. We have one tomorrow on the developmental disabilities community and with chairs in both the Assembly and Senate and the Commissioner from OPWDD. And then next week we have 2 for one for child welfare and one for youth justice. So please join us for those as well. And if you know anyone who's missed today or any of the other town halls, we'll have all of them on our website and on our YouTube channel. So again, thanks for being here. I want to shout out a special thank you to Brad Hansen and Zach Hilmer for their hard work in organizing all of this. It could not be done without the 2 of them. They are just unbelievable and stressed, I'm sure, but we are getting through this. And the other thing I want to just remind everybody about is our Family Empowerment Day, which is in the Legislative Office Building in Albany on March 19th. It's an all-day event. If there's a bus coming from your area, please get on the bus. We would love to have you here, and you'll have an opportunity to meet with legislators that are on these committees that are important to you, and to connect with other people and to hear wonderful speakers. So without further ado, I want to introduce, we have our senator who's the chair of the Mental Hygiene Committee and also the sponsor of our Family Empowerment Day, Senator Samara Brook. And we also have Commissioner Ann Sullivan, who is the Commissioner of the Office of Mental Health. And we're going to have joining us Assembly Member Gunther, who's the chair in the Assembly. So I wanted to just introduce Commissioner Sullivan quickly to do just a 3-minute introduction, and then we're going to turn it over to Senator Brook, who is on a time crunch, and we want to give her a little bit more time to just respond to the questions that we have for her. Commissioner?
Thank you so much, Paige, and thank you everyone for having me here today. And also thank you all for everything you do, for being a voice for youth and families, and for being a partner in so many of the services and things that we do across the state. So a huge thank you, first of all, to all of you. Just to kind of give a very brief update, because of 2 minutes. One is last year's budget was unique. It was huge. It really was a historic budget for OMH and basically for mental health across the state. On the youth side, a number of things which we've put out the dollars for included an investment in Healthy Steps. You know, that's a very early prevention program in pediatricians' offices. School-based clinics, we increased the number of school-based clinics last year by about 200. We're hopeful to do as much this year. We have a total, if everything comes through this year, of over 1,200 committed across the state, which is terrific. It's really exciting. But we also got an infusion of dollars for some very special services for youth last year too, which included Youth Act, home-based crisis intervention, and working with mental health first aid, et cetera. So all of that of last year, just to reassure you, those dollars are out and happening. And that of the $1 billion, 900 million has gone out, and the other 100 million is going out in the next 4 to 5 weeks. So just to reassure you, all the dollars are there. Briefly, for this budget, it's a continuation of that emphasis on youth, the emphasis that was placed by the governor on her summit and on the youth listening sessions we had. So in this year's budget, again, now school-based services for any school that wants it. And please, if you're in a school district that doesn't, or a school that doesn't have it, please contact our field offices. It's so important. We can really get school-based services anywhere across the state that people want them. And I think that's really totally, completely exciting. Also, the Youth Act teams, additional 12 this year. This will bring to 42 Youth Act teams across New York State. So it's not just a pilot program, something that we put out to see if it works. We've been getting good responses for Youth Act, and now it's something which is statewide and will continue to grow if we have to. And then also this year, you will see coming out very soon, the critical time intervention teams that will wrap services around families, often the most intensely, individuals and families most intensely involved in emergency rooms or hospital stays. And these teams will work with them and connect them to transitional beds. So that's another thing that's be coming out this year that we're also very, very excited about. And then a lot of teen mental health first aid. One of the things we heard in the summits was teens want to help teens. And so we're going to be working with a lot of schools for teen mental health first aid, also for youth mental health first aid, et cetera. And throughout the programs that we're putting up, for example, the CTI team I just mentioned will have family and youth advocates. So throughout the system, we are incorporating people, families and youth with lived experience. So I'll stop there because I don't want to take up Senator Brooks' time, but and then I'll answer all your questions. But again, I think it's a very, very positive budget for youth and families across New York State.
Thank you, Commissioner. Senator Brooke, welcome. Thank you so much for joining us. I know that you've got a crazy schedule at the Capitol today. So thank you for taking the time to address our families and young people. And I'll just turn it over to you.
Thank you so much, Paige. And it's always wonderful to be with my partner in good trouble here, Commissioner Sullivan, who outlined a lot of the really honestly incredible things that the state is doing. And I have to also thank Brad and Zach, because I know how much goes into all of this. And I know that there have been a million emails back and forth so that we could make this happen. But obviously every year we make sure that I can join this because it's just such an important moment, really, because I love hearing from all of you, but also that you need to hear from us as your legislators, right? More than just kind of a press release and rallies, you also need to hear what we're doing every day to make sure that we are putting families first and children first when it comes to especially mental health. And so, I think that the commissioner outlined a lot that New York is doing. And of course, my job as the legislator is to push us to do even more because we do see, and we said it again and again, and I wish I didn't have to say it again, but this is the crisis of our lifetime. And when we look at especially youth mental health, we just unfortunately still are not reaching all of the young people that we need to reach. And so when I hear things like 1 in 5 children in New York have mental health needs, right? And we know that the strain that provides or that creates on families. We know that while the need is going up, the demand is continuing to go up and the supply is dwindling, right? We unfortunately have had a history, not just in New York, but really nationwide, of not valuing this workforce in the way that it needs to be valued to make sure that we can keep all of the amazing, passionate, caring, licensed, trained individuals in these roles, because at the end of the day, that's what our families need and that's what our children need. And wait lists are not acceptable, right? Having someone wait 18 months, even 6 months, 3 months for a child, that is an eternity. And when I sit here and think about even my very, very young one, 3 months, she's a different person developmentally. She has grown so much, at 2 years old. But there are young children who need these interventions. And so as we are going through the budget process right now, very focused on, of course, our workforce, making sure that we are getting a 3.2% COLA so that we can make sure people are there to open the door and pick up the phone when you all are looking for that care for your families. We also need the $195 million enhancement to children's outpatient rates for community-based care. I was talking to someone the other day about the fact that the only option they had for their child was to go 3 hours away. That is not a choice for many families. In fact, that child needs to be with their family. That parent needs to be able to go to work. And we have to be able to infuse this funding to make sure that each of our communities have the care they need. We think about things like loan forgiveness, scholarship programs, tuition assistance. We want more people to go into these roles so that we have what we need, and that it's not always about, when a young person or a family is in crisis, we want you to be able to find that care at that first moment when you're looking for it to avoid the crisis as we look at the entire continuum of care. So in New York State, I think both the governor, the commissioner, the legislature understand that the voices of parents, that the voices of youth not only need to be considered, but they need to be at the center of all of our considerations, at the core of our decision making. So not only have I started a youth mental health advisory board in my district, but we are also asking for one statewide. And this is actually something that I took from other states who have done great work and really learned how to bring youth to the table in a way that is genuine, authentic, and effective so that their voices are not tokenized, but that they really are driving the agenda. Because at the end of the day, they often know what they need, right? And so that is something else that we're going to be fighting for, along with a program that Colorado launched during COVID as they were getting ready to go back to school. It was called I Matter. And this was something I learned about from a colleague in Colorado around offering free telemental health visits to any young person, no questions asked, anywhere in the state. And they identified that children having gone through trauma, right? Compounded trauma, not just of COVID, but everything else that happened during that year, they needed extra supports. And so not only are we looking for supports in the schools, which is tremendous, you know, the commissioner talked about an expansion for school-based mental health clinics, but also the realization that not every young person's going to feel comfortable going in that environment. And so how do we make sure we aren't leaving anyone behind? So this program would allow any young person to sign up, go through, get 5 free telemental health, or if they have an in-person provider close to them, in person. And the idea being that in that moment when you absolutely need to get paired with a provider, this creates a stopgap essentially to get you through those 5 appointments onto a treatment plan and hopefully tide you over until you are able to find a long-term provider. But this is not a one and done. There needs to be, right, an entire toolkit, a holistic approach of how we are actually going to deal with our mental health crisis. And, you know, I urge you to continue to think creatively around how we as legislators in government can really step up and have the courage to help present solutions that are actually going to be helpful. And so I'll leave it there. I know I saw one chat at least pop up, but I'm happy to answer 1 or 2 questions before I go to conference where we're going to be talking about more of this to make sure that we can actually get some of these things done in the budget.
Thank you, Senator. I'm going to turn it over to Brad, who's going to decide if there's a question that we can get directly to the senator before he has to hop off.
Yeah, I think, Senator, if you have a few minutes, there is one specific question I think you should be here for. It's one of our prepared ones. So Danielle, if you want to jump in and talk about, crisis intervention, go ahead. Ask your question.
Thank you, Brad. Good morning. My name is Danielle Winter, and I'm the Youth DEI Engagement Coordinator at Families Together in New York State, and I am a young person living in New York City. Given the alarming rates of undesirable consequences during law enforcement interactions with individuals experiencing mental health crisis, are there plans to improve collaboration between law enforcement, EMS, mental health professionals, and peers to prioritize de-escalation techniques and trauma-informed approaches in crisis response training? Additionally, how will the state ensure widespread access to crisis intervention training to minimize harm and promote positive outcomes for those in distress, considering models like Cahoots, which is the crisis assistance helping out on the streets, that have shown success in other cities across the country? Families and young people truly feel a sense of urgency around this issue, and can we really wait for a task force to tell us what we already know is needed?
Thank you so much for that question, Danielle. And I have some good news and then I think a call to action for all of you to help us get this over the finish line. But you're absolutely right. And, you know, I represent the city where Daniel Prude was killed in the throes of his own mental health crisis, which is why we introduced Daniel's Law, because we learned quite quickly after dealing with this, you know, personally in our own city, that there were cities and states all over this country who have understood for a long time that we cannot criminalize mental health and that we have to create a response system that actually responds with compassionate care and resources with licensed and qualified mental health providers, peers, crisis counselors when someone is in a mental health crisis. And so it sounds like you probably know this because you mentioned the Cahoots program, but Daniel's Law is based on the Cahoots program. which we all know has been wildly successful in terms of diverting law enforcement away from those in mental health and substance use crises. You know, a lot of times I remind people, this is the only medical emergency where you're sending an armed individual to interact with someone in a medical emergency. These are medical issues. We need first responders who can actually show up and have the right training for that. And so that's what Daniel's Law will do. And you're absolutely right. We cannot wait for the task force to until 2025. I will say I have to give a shout out to the commissioner. Commissioner Sullivan has said time and again, and really done this work in earnest with the task force to say they know they're not going to wait until 2025. And they are pushing to get that done as soon as possible. But in the meantime, what we can do and what I'm pushing for in this year's budget is to put actual funding behind Daniel's Law pilots. So one of the things we have in New York, and this is why we want the entire law statewide, is we have a patchwork right now of different response systems, right? So if I have a mental health crisis in Rochester, I'm going to get different care than if I'm in Brooklyn or if I'm in Yonkers, right? So that's the point of Daniel's Law, is to make sure we don't have a patchwork and that we have a state framework. But because there are programs occurring right now that follow the tenets of Daniel's Law and programs like Cahoots, we have an opportunity to actually fund those at a larger rate and actually see them in action, and even perhaps bring that information into some of the work the task force is doing. So this year, my big fight is, last year we tried to get a task force and well, let me be correct. Last year, we tried to get Daniel's Law passed, and we were unsuccessful in getting it. The compromise was a task force and a pilot. And then we ended up finally losing the pilot and only getting a task force. This year, we want to finish that job. We need to get that pilot for Daniel's Law funded. And so that's what I'm focused on. And that could be dollars to your municipality this year to make sure that they can fund programs like this, which is absolutely what we need. And with that, I'm being flagged that I've got to get to a conference. So I just want to say thank you all so much. I love having you in Albany every time that you're here. I love this opportunity to speak with you. And please know, for all the families and all the advocates on here, that we do not take for granted the time you spend advocating for your families and for families across New York. And your stories stick with me when we have those hard negotiations and those discussions. So thank you so much.
Thank you, Senator. See you on the 19th.
Thank you, Senator. I was going to pass the question over to Commissioner Ann Sullivan.
Hi, thank you so much. Yeah, as Senator Brooks said, the task force, which I chair, has been working very, very hard since the summer of last year, as soon as we got started, to do what was asked for in the legislation. And this legislation wanted three things. First of all, they wanted us to do a survey of everything that's happening in New York. They wanted us to look at a whole host of national models. They wanted us to come up with a funding mechanism that could support a model across New York State. So it does take a little time to do that. The initial legislation was until 2025. I know we are not going to be waiting till 2025, December 2025. We are hopeful to come up with the recommendations this year, and hopefully, well, I don't want to give a date because the task force might shoot me, but close to, so that we could really have a plan for this year. Now, we've already talked with the Coots model, which people have mentioned, and it's a good model. There's other good models too across, and I think we have to sit down and discuss it. The principles that the virtual sessions and the in-person listening sessions have been putting forward are what we're going to be using. And that is to make sure that anyone in a behavioral health crisis gets the opportunity to have that behavioral health crisis dealt with by a mental health professional. And that's the goal of what we're talking about. So we're looking at different models, we're looking at different financing mechanisms, we're looking at things that could possibly be a statewide approach, even if it was pushed out sequentially across the state. So I really want to emphasize that the task force is working very, very hard. We've had 4 listening sessions, which were also asked for by the legislation. We have a group that is putting together and is doing the survey for us across the nation and across New York State, and they're going to be presenting their first look at the next Daniel's Law Task Force meeting. And we have also heard from the person who founded the Coots model way back as to how that works and how that has evolved. That's been a 20-year endeavor that has evolved into various phases. And also we are talking to another city that has adopted the Coots model. So we're looking at multiple things. Please know that this is being taken very seriously, and we're going to come forward with the recommendations as soon as possible. And the task force is working very hard. So we'll hopefully have good news for you soon as to what we would recommend.
Thank you.
Thank you. Thank you so much. I will offer maybe an additional follow-up question, Commissioner, and that's, I think, around crisis intervention in general. I understand that there is quite a bit in the budget this year around things like youth act teams and things like that. I don't know if that's something you also want to speak on a little bit.
You know, we have the bones of a very extensive crisis system in New York State. It's not everything it should be, but in many ways it's quite comprehensive. So it begins with 988 and the training which is going on for 988 in terms of being able to answer just about anything. So for example, 988 is being trained in answering crises for individuals who are substance users, crisis for individuals who are developmentally disabled, crises for maternal mental health. So that basically 988 is your entry point. How 988 ultimately will interface in our communities with 911 is something that the task force is working on. And some communities have done an interesting job already in Westchester and a few others that have really done some very tight knit. So you begin with 988. Then you have to have the bones of a system that can respond. And the first thing you want is mobile crisis teams. And we do now have mobile crisis teams available throughout the state. Now, they're not all 24/7. And that's what ultimately they should be. But many of them are growing and many of them are getting closer and closer to that. Many of them now are like 8 a.m. to 9 p.m., 10 p.m. and available in some areas within 15 minutes. They've been able to get out, not across the state, not universally. So we are growing that, and we're going to training. And the training for those teams includes youth. And we are working on having more and more peers involved, whether adult peers or youth and family advocates on those teams. Not universal yet, but that's something that would be something we've been pushing for in a big way. Then we have a series of crisis residences, and the crisis residences have grown across the state for youth. I think we have something like, I don't know, 20, over 20, I think now. Crisis residences for youth, we probably need more. There's crisis stabilization centers that are beginning to come up. The crisis stabilization centers will serve adults and youth in an intensive way for up to 23 hours and then connect to services. The CCBHCs are growing. Why are CCBHCs important? Because they also have some crisis capacity, and they have to take anybody who walks in the door, and they are well integrated between mental health and substance use, and so are the crisis stabilization. So we're building a system that can respond, because while whatever model we come up with, which deals with people in acute crisis, you don't have the bones of the system after that, then it doesn't work. So you need to have the whole thing built, and it's growing. So, and then we have for youth, we have Youth Act, which is incredibly effective, and home-based crisis intervention, which works right in the family's home for up to 6 weeks for youth and family that are in crisis. So if a mobile crisis team sees a family and youth in crisis because they got a call from 988, they can connect to home-based crisis intervention, which will come into that family, and that is growing across the state. Now, I keep saying growing because we're not there yet across the state, but there's a lot of dollars that were in last year's budget and this year's budget to begin to push it statewide, and that's why it's so exciting. These are not just pilots. These are attempts to really try to cover the state. It'll take a while to get there. I think you're not going to see the real impact for another year, two years as all these services come out, but I think that there is an attempt to work with communities, most in need and having the most need across the state. And we've looked at that when we put out the RFPs, et cetera. So I think we're in a good place to be building this. We need your input. You know, when we started Youth Act, we didn't know exactly how effective it would be. And we got a lot of feedback from you and from the provider community and from the families, and we've modified it. We've made it different. We've made it suit the needs of the families and the youth who come to us. That's what we want to do with all these services we're putting out. So we need your feedback. If it's not working, or if there's something else that needs to be there, we need to hear from you, because that's what makes it ultimately effective. So there's a lot of the other crisis work is these, and this is new, so you got to again bear with us because we need your feedback. There's something called the critical time intervention teams. They are wraparound intensive teams that will work with youth. You know, we all know this problem of our young people being in emergency rooms. and coming in an emergency status. And the hospital saying, well, you don't need an inpatient bed, but what do we do now? Where can you go temporarily, maybe, while you get a lot of help before you go back to your family? Who can be there and come meet you in the ED and help you move? That's what these CTI teams are all about. And they will ultimately be linked to like 6 to 8 bed residences where youth can be temporarily if they need that, or just work with the family. If they can go home and the family says, yes, it's okay as long as somebody's really there to work with me and we connect the services. So those teams coming out, again, it'll take time, but they will be linked to the inpatient and ER system so that individuals and families there get the help they need. So again, it's an attempt to have, multiple needs because there's no one size fits all
Right.
in this world. So there's a lot coming out. We need your feedback as to how it's working, and we need a little bit of your patience until some of it is out there because it takes time to hire. And I know the workforce issues, but we'll leave that for a minute.
Yeah.
But believe it or not, we've been able to staff the majority of these youth act teams, which is terrific, and they're having an impact already.
Thank
I
you,
know that was
Commissioner.
long-winded, but sorry.
Well,
No,
and
I
just
queued you
wanted
up. So
I want to say thank you too to the commissioner for recognizing that you need our input, and we are here to give that. That's why we're here today. That's why we'll be here in Albany on 19th, and that's why you see us all the time, in meetings with you.
yeah. So anyone that's in the audience right now and you're wondering, should I write this email to the OMH or should I write this email to Families Together? The answer is yes,
Yes.
because that's what makes these things better. That said, in the Q&A, I did see a question about staffing and the concerns about new programs coming up and how that relates to existing programs and the overall workforce pool and concerns about shortages. So I think that is you kind of spoke to that a little bit, Commissioner, and I think our next question is focused specifically on that, the idea of workforce. Tamara, do you want to jump in and ask your question? You're on mute.
Good morning, Commissioner. My name is Tamara Bigel, and I'm a proud Long Island mom, co-president of the board of Long Island Families Together, and a Healthy Minds, Healthy Kids Council member. While advocating for both my son and other children, a theme has emerged. Families need workforce, not wait lists. As the governor stated this year, for decades, our mental health system was deprioritized and defunded. Make no mistake, this is the defining challenge of our time. I strongly agree. Since 2006, over $500 million has been divested from the children's behavioral health system due to deferred cost of living adjustments, COLAs. Furthermore, outpatient behavioral health service rates under Medicaid are unsustainable, and commercial insurance pays 50% less on average. As a result of this lack of investments, families and young people experience workforce shortages and wait lists that can last months or even years. Tens of thousands of your constituents are still waiting for in-home and community-based services. To reverse these trends, we need a drastic investment. That's why we call for $195 million investment that would expand outpatient services like CFTSS and HCBS and clinics to over 26,000 youth, as well as a 3.2% COLA and fair commercial rates. If these investments were in place, perhaps my son would have received the services he needed at home instead of being ripped away from my family. And if you make these investments this year, perhaps he could access these services when he transitions back home from residential. The need for investment is urgent. Our children are self-harming, attempting suicide, and dying. As leaders of New York State, what will you do to reverse these trends and meet the immediate mental health needs of our young people within their communities?
Oh, thank you very much for that. And you're right that it's unacceptable that people have to wait for critical services that can help our youth and keep them with their families. So you're absolutely right. Let me say a couple of things that I think are important. First of all, I know the COLA is an issue, and but I just want to reemphasize that 1.5% is in this year's budget. That last year was, I think it was 4%, and the year before was 5.4%. While that's not doesn't make up for the decades of not funding COLAs. It is there. And in addition to that, we have significantly increased rates for clinic over the last 2 years, 10%, increased rates for things like partial hospital and some other specialty services, 25%. And those rates are permanent. In many states, those rates came after the pandemic and then they went down. New York is committed to not just having those rates up there. HCBS rates went up, et cetera, to help the providers. The third, and this is a very important point that you brought up, is commercial insurance, because I do believe that for far too long, we have been starved on the commercial insurance side, and especially on Long Island, where there's a large population of individuals who are insured coming to our clinics. So in this year's budget, and we really need your advocacy for this, because there could be significant pushback by insurance companies. There, in this budget, there's a provision that would say that the commercial companies have to pay at the same rate as Medicaid. That is critical. Nowhere else in medicine does commercial pay less than Medicaid, except behavioral health. In fact, throughout the rest of the medical system, Medicaid is the lower payer, and commercials up there. I won't go into the reasons and the stigma and the issues as to why mental health falls into a different position, but it does. And we really need your help with that, because for far too long, the state has been picking up the cost of what the commercial insurers are not paying. So that's one thing. The other thing I think that it's important to keep in mind is we have, going through what's called the Department of Financial Services, 3 key regulations for access. These are the people who say to a managed care company, you have to do this. It's located in the Department of Financial Services, which is connected to the Department of Health. It's not really us, but we've worked very closely with them. And 3 key things. One is a 10-day appointment availability for mental health. 10 days. Now, other states have done this, and we have a lot of pushback, again, from the managed care companies, but this is really their job, to make sure that they have networks that can provide that kind of access. The second is, if they don't have a 10-day availability within their network, they have to go out of network, and with no additional cost to the consumer, no additional cost to the family. So you'd pay the same thing you would pay if you were, whatever your in-network insurance covers. That's really critical. And third, they have to have real directories. I mean, we've all been in this situation, and I've been in the situation too, where you look for somebody who's under a particular plan, and then you say, well, I don't take that insurance anymore, or I'm full, or I can't see someone, and you go through pages after pages and you can't find anything. So they have to really update the directories. Those regulations are coming in a separate vein, but have been put there by, under the governor, saying this has to happen. They're now out for comment. They're out for public comment, and well, they should pass. They should pass. So we need advocacy for that. So that begins to say to the insurers, this is a partnership. This is a partnership in making access, that we have to make sure, we have to have all these services, but now you've got to make sure that you're paying for them and that they're included in what you do. And then the other on crisis availability, I think one of the, it's critical that a home-based crisis intervention and the other services, that we have enough of those. And we're getting a sense as we build them up across the state as to what the need is. But again, there should be easy access. A crisis service by its nature says it's a crisis service. It shouldn't be something that you wait for, because then it's not a crisis service. A crisis service should be something that is there when and where you need it. So there's an investment, a large investment in that. The other thing is what we've had success with for the workforce is loan repayment. Loan repayment, the first set of loan repayments that we put out were for psychiatrists and nurse practitioners. And at this point in time, we have almost 95 psychiatrists who bought into this across the state, and almost 150 nurse practitioners. So that's 200 people who, for loan, over 200 for loan forgiveness, who now owe us 3 years of service in our system. So as we keep rolling out loan forgiveness, then we said, okay, well, what about everybody else? Social workers, psychologists, et cetera. So we have $5 million for that. For that, we've already had 600 applications, but it's probably 500 slots. So that over the next year or two, we will be growing that. And then in addition, 4 million specifically for child services. So an additional 4 million in loan repayments just for individuals who will work in child services. And that includes everybody. That includes social workers, et cetera. This has been successful in getting people into the system. And we think if we continue to grow this and roll it, That's one of the things. The others, we have some fellowship dollars for underserved that we've been using with SUNY and CUNY to get some individuals from underserved into the system. And then something unique that we're doing with child services is paying for training in evidence-based practices. I mean, what keeps you in a job after those? I mean, maybe you're in the job because you're getting your own repayment, but why else might you stay? You might stay because you learn things and because it's an environment of learning and growth. And that's a kind of retention strategy. So we pay for the training for these evidence-based practices to the providers because it's costly for them to do it. So those were growing out. It does two things. I think it keeps people and it gets the care to another level of what we want, which is using increasingly evidence-based practices. So so solving the workforce crisis is dollars, but it's also, I think, people wanting to work in the area, people getting loan forgiveness and other incentives. So we're working hard to see. And just to remember, this is a national phenomenon. Post-pandemic, across the country, there's been this workforce shortage in mental health, but also in healthcare generally. So I think it's something we're all struggling with. But I think we're open to your ideas. Any other ideas you guys have that could be helpful? And the other thing we're looking at is also a paraprofessional workforce that might be able to help social workers and psychologists, et cetera, work to the top of their license while they might assist. And we're in the process of looking at what that might mean. We've also have grown in all these services the opportunity for people with lived experience to be a part of those services. And we are definitely involved with you and with our peer training and everything to kind of grow the peer workforce, which is also so critical, so critical. So there's a number of things we're doing. I don't know if they're bearing fruit yet, but I'm hopeful that they will as time goes on.
Thank you, Commissioner.
Thank you. Thank you for the question. Thank you.
Thank you, Commissioner. And for our audience, I put a link in the chat. There is a take action that we collaborated with the Council for Community Behavioral Healthcare around the commercial rate proposal that's in the governor's budget. So you can take action right now if you want, and let the Senate and the Assembly know just how important this is to access, bolstering that point about both being involved and also how important and the political pushback that we're likely to see from the insurance companies, who are a very powerful interest group. So we have to be way more powerful, right? And another point in response, Commissioner, really appreciate what you outlined there. And also, we will continue, for our audience members knowing, we're going to continue to push for things like better rates for CFTSS, HCBS, and clinics, not just these good models like CCBHC, but all clinics everywhere to try to address that workforce and scale up capacity. So that they're, that North Star of no child should wait on a wait list for very long, if at all. But we appreciate what investments have been outlined so far. That I think, we believe they will make a difference. So next, I want to jump in. We've been talking about funding. Let's talk a little bit about how systems collaborate together and what that feels like as a parent, as an individual, when systems don't seem to mesh. And to talk about that, I'm going to queue up Semka Weinstein.
Thank you so much, Brad. I firstly would like to thank Families Together and our esteemed panelists for this opportunity. It really does mean the world to me. So as a neurodivergent advocate of a young adult on the autism spectrum, it is common for autistic individuals to be diagnosed with co-occurring mental health challenges. In fact, statistics show that as many as 80% of autistic people carry at least one comorbid psychiatric diagnosis. And according to one study, are 9 times more likely to present to the emergency department for psychiatric reasons than their neurotypical peers. Been there and done that. Systems like OMH and OPWDD are often siloed, and there's seemingly confusion over which is responsible for providing mental health services to the autistic population. So, no pressure. How can we adapt our existing mental health resources to accommodate the evidence-based best practice support for the mental health needs of the neurodivergent population? Thank you.
Thank you so much. And you're absolutely right that we have not historically, we have not worked together the way we need to. And some of that issue is, a big issue of that is training and people knowing what should be done. Let me go through a few things that we're doing that I think will be helpful. And we need to be in a partnership ongoing to see how helpful they are. So first of all, beginning with the access to services at the community level. We are going to be working with our CCBHCs. Now, why the CCBHCs? Because they have a little, as Bradley, you had mentioned, they're a little bit better off financially, and they have a little more flexibility in how they're paid. So one of the major initiatives this year, especially for the new, but also all the existing 13, so this will eventually cover 39 CCBHCs. We're going to be doing intensive training on dual diagnosis and how to work with individuals. Sometimes at our doors and our mental health clinics, we say we don't know what to do. And that's not acceptable. That's just not acceptable. So the first rung is to get those basic services to be able to serve individuals, both who have developmental disabilities, like, as you were saying, autism spectrum, and mental health issues. Also in the crisis stabilization centers, we're going to be doing a lot of training for individuals. We have also done some initial training, which has already started with 988. So that when people call in, they have an understanding of the issues and they know how and where to refer. So at the basic first level of contact and services, we have to do better. And we've been in touch. There's a number of places across the country that do this work with mental health clinics and do the intensive training that will work. And we're picking it out now who we're going to contact with to make sure that that happens. Then when you go to the next level of intensity, this is where, again, we have to work together. And let me just say that everything I just said is we're talking with OPWAD about it, getting their advice, getting their help, etc. The next level of intensity involves a couple of projects. One is, I kept talking before about home-based crisis intervention. And for the first time, we have actually put out the RFPs for home-based crisis intervention dealing specifically with individuals who have dual diagnosis of developmental disabilities and mental health. And we're starting 2 teams, I think, across the state. And I'm sorry, 5 teams across the state. How about that? 5 teams. It was 2, now it's 5. That will be available across the state to do that home-based crisis intervention specifically with individuals. That means they need special training, we need special behavioral experts, I forget that title, but they behavioral expert on those teams to work with the families. That's really new. And once that comes out, I think that will have a significant impact on families that are in crisis. Similarly, those CTI teams that I talked about are going to have on the team a specialist in developmental disabilities so that individuals can also go to those residences with the help that they may need while they get the other services that they get. So we're trying to really integrate at the different levels. And then at the top level, this has been long in coming, and but I think as of July, an inpatient service connected to SUNY Upstate that will has been a partnership with SUNY Upstate and Hutchings, our psych center. So they have taken over the child inpatient beds from Hutchings, and I believe it's 11 of those beds will be for individuals with developmental disabilities and mental health who need inpatient. Now, that's a small percentage, but they need it in a very specialized environment with step-down capacity and working with SUNY. Why SUNY Upstate? Because they have the experts there. They have people who've done tremendous work in this area, and you want to make sure that you have people, especially on the inpatient side, who are trained. So at each level, now all these things have been done together with OPWDD. And in addition, the individuals now leaving the hospital, there's going to be wraparound something called Care Pathway, which will work with, again, the families and those individuals. The goal here is to help families keep their loved ones with them, keep their youth with them, both adult and child. And there's a whole bunch of adult stuff going on too, but both adults and for youth. But when needed, the crisis services are there, and when needed, the inpatient services are there, but people don't get stuck languishing. And again, guys, it's just going to take some time for some of this to roll out, but I do want you to know that a big piece of the planning, $1 billion, that this chunk of the planning was there because of your voices, because you said to us, guys, you're siloed, you're not doing what you need to do together, you got to work together. And so that the things that I'm describing came out of that, and a lot of feedback from people as to what's needed. So I know it's not there tomorrow, but pieces of it are coming out. And the home-based crisis intervention, 2 of them are starting now. They're actually out there in the field. The other 3 will be added, but they're actually doing the work. So some of it's there, and some of it is to come.
Thank you. Thank you, Commissioner, because the outcomes will define the mental health of a generation. And at Families Together, we're here and we're ready. So thank you.
Thank you. And your work with us will be critical in all this. So thank you. Thank you.
Thank you, Commissioner. Julissa, you made it. Julissa was waiting on an appointment that she had to make. It's very related to her question. She was waiting, I believe, 6 months to get this appointment. And we were unsure if you're gonna be able to make it. So I'm glad you're here. It's your time. Go for it.
Thank you so much. Yes, I'm sorry for being late. So my question is, there's a couple things to my question. ADHD, I'm diagnosed with ADHD. Both my kids are diagnosed with ADHD, and my youngest son also has autism in addition. ADHD is seen as both a mental health disorder and a learning disability. However, like specific treatments like executive functioning therapy is not covered by Medicaid or commercial insurance, despite its effectiveness in helping several different learning disabilities and mental health disorders. 6 to 9% of children ages 3 to 17 in New York State are diagnosed with ADHD. I've tried to get it covered under OMH care coordination in order to help me to also give the support to my kids and also to help my kids. They've only approved $200, and that covers just the intake and not the actual executive functioning coaching itself. I've also tried to get the treatment through my insurance, and I've been looking for 2 years, but a lack of updating their resources in the like the formularies. When I call the insurance, they give me doctors, they give me places, and these places are not even in network anymore, or they don't exist. The numbers just ring, or they say it's disconnected. And it's been so difficult in trying to like find anything. I was facing something called a ghost network. I eventually gave up, and now I'm like just at the point where it's taken so much of my executive functioning to try to find executive functioning that it's impacting me, and I've had to take a break from it. But beyond just my own experience, we know that other families that don't have like resources or like networking skills that I do from working in the field struggle to connect with appropriate providers for all behavioral health services. And the Attorney General reported that nearly 85% of providers listed in the directory were actually ghost providers. Secret shoppers illustrate what families like mine experience every day. Endless phone calls to providers that aren't actually a network, if they exist at all. And with medical insurance, individuals can see their primary care doctor and specialty doctors at the same time. But in mental health care, it seems like an individual therapist is your primary, but they also are not covered for specialty therapies like family therapy, DBT, trauma therapy, IFS, internal family systems therapy. And trying to find those specialty therapies is very difficult. In general, they're usually not covered, but those therapies are very proven to help people. What can be done? Like what policies can be changed to make these like evidence-based practices that are like known to like actually help people be more accessible to us? Like what can be done to change this? Because it's been years and it's not changing, it's not getting better, it's getting worse.
Well, thank you very much for that question. And I think I get pieces of it, but just to clarify a couple of things. First, I'd said earlier that we do have DFS regulations which are demanding that they update their directories, that the insurance companies are very clear about what they cover and what they don't, that they update their directories, that there be a 10-day appointment time, and if you can't get an appointment, that you get out of network at no extra cost to the consumer. Those are DFS.
They're, but
Department
they're
of-
not doing that. They're
Yeah,
not
but
doing
they're not
that.
doing it because the regulations are right now out for comment. The regulations will be approved probably within a month. And then there are dollars to enforce the regulations in the budget. So that part is going to happen. Those are the DFS regulations. When you talk about the evidence-based practices, I mean, we are investing in some of the family therapy things that you've talked about as evidence-based practices and working with clinics to make that happen. There are other practices that may or may not be covered by insurers. And I think it might be helpful to have a conversation with you about some of the ones you're mentioning, because we are in the process of going to Medicaid to update what we are including and what the rates will be for various services. So I think I would like to invite you to talk with just email me and we'll connect you about exactly which services that you're talking about that we are not covering, or we are not covering in a way that is financially viable to actually have them. So for example, several family therapy things are covered. The problem is that a lot of places don't know how to do it. And so we are investing on the Medicaid side with training our clinic system to be able to know how to do it so that they can then say, yes, we have it and we're getting paid for it. And we're paying for the training because the training in some of those evidence-based practices is expensive. So we are doing that to grow those. Some of the others that you mentioned, I'm not immediately familiar with, and I think we would need to talk about which ones you think are the most critical that we either do training for or lobby to get on the Medicaid roster if they're not, or look at the rates. We are going back to them about certain things for individuals who do certain behavioral therapies with individuals with autism, et cetera. But I'm not sure if it covers exactly what you're saying. So I think it would be helpful to have the conversation with you about those. So we are invested in looking at that. I think the DFS regulations are coming out and they will be enforced, and that will, I think, change the landscape in terms of the responsibility for insurers to have services available and to say that they will pay for what's needed. Then some of these more complex services, then we have to work, especially with commercial insurers as well as Medicaid, to make sure that they cover these when they're needed. And that's where the beginning to say getting pressure on commercial insurers to treat behavioral health issues differently is so, so important. But I think, so let's talk about some of what you're saying particularly and see where that fits into the spectrum of things that we're lobbying to change.
Okay, can I put my email in the chat for you?
Yes, please do, and we'll get back to you. That would be great.
Thank you so much.
Thank you, Commissioner. Brad, can you follow up with just a little bit about what DFS is and what, because sometimes there's acronyms and people don't know that financial services is actually insurance. It's kind of a confusing.
Yeah, the Department of Financial Services, that's what Commissioner is talking about, that regulates insurance companies, and the network adequacy rates that are the network adequacy regulations that the Commissioner is talking about pending right now. That means that they're open for public comment. The providers and citizens that are invited to weigh in on those things. And one of the key ones that the Commissioner is talking about is that 10-day, if they're not in network, they can't provide an in-network service, that they then have to pay for it the same cost for out of network. That's right. Am I correct? And that's the specific part of that regulation that you're talking about. That could possibly affect the issue Jalissa's talking about.
Yeah, because some of the insurance does cover executive functioning, but as an out of network, they don't cover it in network. But if you have out of network benefits, then they'll cover, like, I think 30 to 70% of the cost. But with Medicaid or Medicare, it doesn't cover it at all. Like, there's no way around it. So I'm grateful that this is now going to be implemented, because like that's the struggle I'm encountering.
Yes, so great. So thank you. And we'll look at, because, working with insurance and actual codes and what gets covered is complicated. So it'll be great to talk with you and try to understand and see what we can do.
I put it in the chat. So let me know if you see
Yes.
it. I put it in there.
And I know that Tamara also wants to be a part of that conversation. She has similar thoughts and helped Jalissa craft this question. And I'm sure there's plenty of people in the audience that probably feel similarly. So we'll make sure that we have opportunities for follow-up after this. I do have to say that time is up. And believe it or not, we have more meetings we have to do right after this. But I think just want to point out, one, we have evaluations that we really need people to fill out. This helps make sure that we do a good job, that we're meeting the needs and helping people feel empowered to be involved in advocacy. We need that for our reporting too. So for all these grants and things we need. So I'm going to repost this in the chat. Please fill out this evaluation form and select mental health and let us know what you think about this. Thank you to all the ambassadors for being here and asking such thoughtful questions. Thank you for the audience for being here, and thank you, Commissioner, for being so generous with your time today.
Thank you. It's been a pleasure. And we'll follow up on those issues with you guys. Thank you so much. Thank you.
Thank you.
Thank you. Have a good one. Bye.
Thank you.
Take care.